Hello, welcome to Pathagonia. Today we're going to talk about medical lung diseases. Before we begin, if you haven't, please check out Kurt's Notes websites where you can access all of his notes for free. Without further ado, let's talk about where the dominant finding is fibrosis. It appears pink from collagen at low magnification. Usual interstitial pneumonia, UIP, or idiopathic pulmonary fibrosis, IPF. Usual interstitial pneumonia is a histologic pattern which can be idiopathic and therefore called idiopathic pulmonary fibrosis, or due to connective tissue disease, chronic hypersensitivity, pneumonitis, or a drug reaction. UIP is a pathologic radiographic diagnosis, and idiopathic pulmonary fibrosis, it's a clinical diagnosis after excluding other etiologies. The typical idiopathic pulmonary fibrosis presentation is an older male with gradually increasing shortness of breath that eventually becomes fatal. Histologic pattern findings include temporally and spatially heterogeneous, meaning the disease is patchy. With the classic findings are fibroblastic foci, as mentioned, which is immature fibroblastic areas, and honeycombing, which is architecturally distorted cystic spaces with respiratory epithelium and surrounding fibrosis. The fibrosis is worst in the lower lobes adjacent to pleura and septae, so can't diagnose on a transbronchial biopsy. Asbestosis. This is caused by the inhalation of silicate mineral fibers, not just asbestos. It's often an occupational exposure in miners, construction workers, shipyard workers. Key findings are 1. Interstitial fibrosis, and 2. Asbestos bodies. However, the diagnosis is often made clinically. There's minimal associated inflammation, fibroblastic foci are absent, and these asbestos bodies are dumbbell-shaped iron deposits, and it highlights with iron stains. And you often also see pleural plaques, and there's an increased risk of lung cancer and mesothelioma. Hard metal pneumoconiosis. This is caused by inhalation of hard metals, usually cobalt. Other metals include tungsten, titanium, and occupational exposures amongst those in manufacturing, drilling, sawing. Histologically, you'll see giant cell interstitial pneumonia, and you'll have intraalveolar giant cells and fibrosis with variable inflammation, and you have frequent peripoiesis. Erdheim-Chester disease. This is a multisystemic histiocytosis that can involve any organ. It frequently involves long bones also. In the lung, you'll see broad fibrotic bands with intermixed foamy to pink histiocytes and scattered Teuton-type giant cells, which we can see. The macrophage is stained with CD68, factor 13A, S100 positive or negative. Some show BRAF V600E gene mutation. Pleural parenchymal fibroelastosis. The early stage, you'll have upper lobe predominant subpleural fibrosis with mostly elastic fibers, which you can highlight with elastin stain. Microscopically, there are smaller, lighter colored, kinkier fibers than collagen. It's a rare diffuse interstitial disease that can be idiopathic or associated with stem cell transplantation, medications, exposures, and you'll have minimal to no inflammation, granulomas, fibroblastic foci. If localized apical mass lesion, consider apical cap, which is a common pleural-based fibroelastotic lesion which can mimic malignancy. Other fibrotic diseases. Many diseases that may initially start out in a different pattern can become fibrosis predominant if they become advanced enough, so be sure to look for clues to other etiologies. Smoking-related interstitial fibrosis, where you'll have hyalinized ropey fibrosis, respiratory bronchiolitis, your smoker's macrophages, and emphysema. Chronic hypersensitivity pneumonitis, you'll see cellular infiltrates, particularly near airways, loosely formed non-necrotizing granulomas and or giant cells, and chronic nonspecific interstitial pneumonia, NSIP. The histologic pattern, you'll see relatively homogeneous thickening of alveolar septae by fibrosis of the same age, as opposed to the heterogeneity of UIP. It can be due to hypersensitivity pneumonitis, drugs, connective tissue disease, diffuse alveolar damage, etc. Cellular interstitial infiltrates. often appears blue at low power. Hypersensitivity pneumonitis, due to inhalation of small organic or chemical antigens that stimulate an immune response. Common antigens include birds, your pigeon fancier's lung, molds, farmer's lung, wood dust, certain industrial chemicals. It's often delayed diagnosis due to the insidious onset of dyspnea. You'll have airway-centric inflammation with 1. Peribronchiolar granulomas / giant cells, as you can see here, and the bronchiole here. Peribronchiolar interstitial chronic inflammation, and chronic bronchiolitis. You can also often see peribronchiolar metaplasia or Lambertosis, organizing pneumonia, and cholesterol clefts. If fibrosis, consider chronic hypersensitivity pneumonitis. Nonspecific interstitial pneumonia, NSIP. This is a pattern of inflammation with homogeneous, diffuse thickening of alveolar septae by chronic inflammatory infiltrates. You can see associated homogeneous fibrosis leading to chronic NSIP. It's a better prognosis than UIP or IPF. It can be idiopathic, medication-related, hypersensitivity pneumonitis, or most commonly due to connective tissue disease. Speaking of connective tissue disease associated interstitial lung disease. This common findings to suggest this diagnosis include prominent lymphoid follicles, plus minus germinal centers, pleuritis, inflammation patterns that are hard to explain, classify. If suspicious, consider suggesting rheumatology evaluation. In rheumatoid arthritis, you can see rheumatoid nodules. For systemic lupus erythematosus, or lupus for short, you can have pretty much any pattern appearance. You can have scleroderma, polymyositis, dermatomyositis, Sjogren's syndrome, and mixed connective tissue disease. Lymphoid interstitial pneumonia, LIP. Histologically, you'll see diffuse, dense interstitial lymphoplasmacytic infiltrate, as we can see on our right. It's mostly polymorphous T cells, it's rare, idiopathic, and thus you must exclude other conditions, particularly autoimmune diseases, HIV/AIDS, and immunodeficient states like CVID. Also, you must exclude lymphomas, especially MALT lymphoma. If there's lots of large lymphoid follicles centered around airways, consider follicular bronchiolitis, which is on a spectrum with LIP, with similar differential diagnosis. Hot tub lung. This is a hypersensitivity pneumonia-like reaction to Mycobacterium avium complex, or MAC, which is common in water like indoor hot tubs, saunas, pools. It has a similar appearance to hypersensitivity pneumonitis with the peribronchial or chronic inflammation, but you have more prominent and better formed granulomas, which can be necrotizing. Let's talk about alveolar filling pattern. One is diffuse alveolar damage. This is the histologic manifestation of ARDS, or acute respiratory distress syndrome, where you have bilateral diffuse infiltrates, often requiring ventilation. It can be seen in a variety of settings, and it is the common endpoint, including infection, sepsis, drug reactions, toxins, and shock. If idiopathic, then it's acute interstitial pneumonia. Histologically, you'll see endothelial epithelial injury leading to leakage of serum proteins. Over time, that'll lead to hyaline membranes, and you'll see fibrinous exudate. It's particularly with infection, you'll see necrosis and acute inflammation as well. And here's that hyaline membrane that we can see. Organizing pneumonia. This is a non-specific pattern of lung injury repair. It can be seen after recent injury, infection, aspiration, connective tissue disease, etc. If idiopathic, it's cryptogenic organizing pneumonia, or COP. And histologically, you'll see accumulation of immature myxoid material and fibroblasts within airspace. In airspaces, you can see fibroblastic plugs / polyps. It can be branching, it can be floating. You'll have intact alveolar septae, and often resolves after removing inciting agent. Eosinophilic pneumonia. You can have acute eosinophilic pneumonia, which presents with fever and dyspnea of less than 1 month duration. Essentially, it's diffuse alveolar damage with the addition of eosinophil-rich inflammation. You'll have peripheral eosinophilia and EOs on bronchoalveolar lavage. Your differential include infection, especially parasites, medications, cigarettes, pneumothorax, and idiopathic. Chronic eosinophilic pneumonia, this is an insidious onset and relapsing. It responds to steroids. Histologically, you'll see intraalveolar collections of eosinophils, macrophages, and proteinaceous edema. Also, you can see features of organizing pneumonia. Your differential diagnosis is when idiopathic is often associated with asthma, medications, allergies, desquamative interstitial pneumonia, DIP, or respiratory bronchiolitis interstitial lung disease, RBILD. This is a spectrum of disease highly associated with smoking. For respiratory bronchiolitis, you'll have pigmented smoker's macrophages, as we can see here, in the respiratory bronchioles and adjacent alveoli. As often with adjacent mild fibrosis, and you need clinical symptoms findings to label as respiratory bronchiolitis interstitial lung disease. Desquamative interstitial pneumonia, DIP, you'll have filling of alveoli by pigmented macrophages. It's often associated with fibrosis and mild chronic inflammation. Note, it can be challenging to distinguish these smoker's macrophages, which have fine, powdery, anthracotic pigment, from hemosiderin-laden macrophages seen with hemorrhage and congestion, which is more chunky and refractile. If you did get a Prussian blue, both would stain with iron. Alveolar hemorrhage. This is hemosiderin-laden macrophages and fresh blood in alveoli. It can be secondary to trauma, cardiac disease, vascular disease, medications, etc. Diffuse alveolar hemorrhage is often a result of vasculitis. Be sure to look for capillaritis. Antiglomerular basement membrane disease, or Goodpasture syndrome. This is due to autoantibodies to collagen 4 in the basement membrane. This impacts the capillaries in kidney, lung, or both. In lung, it'll lead to hemorrhage. In kidney, it'll lead to crescentic glomerulonephritis. Lymphoid pneumonia. This is lipid-rich material and inflammatory cells filling the alveolar spaces. You can have endogenous post-obstructive, as you can see here, with proximal airway obstruction. You'll have inability to clear your secretions, and you're going to have accumulation of finely vacuolated macrophages in the distal airways, as you can see here. Exogenous aspiration. This is aspiration of lipid-rich material, think mineral oil, and you'll have accumulation of multinucleated giant cells containing large lipid vacuoles within alveoli. Alveolar proteinosis. This is filling of alveoli by amorphous eosinophilic granular proteinaceous material. The occasional crystals and cholesterol clefts is PAS diastase positive versus edema, which is PAS negative, and you have a crazy paving appearance on CT imaging. There are three forms. Congenital, this is due to mutations of genes encoding surfactant or GM-CSF. Primary, this is autoantibodies against GM-CSF. You have abnormal macrophage function and accumulation of proteinaceous material. And secondary, a variety of causes including stem cell transplantation, solid organ transplantation, etc. The key histologic differential diagnosis is PCP or pneumocystis pneumonia. Be sure to get fungal stains, especially if immunocompromised, because it'll also have this frothy look on microscopy. Alveolar microlithiasis. This is microliths of calcium phosphate within alveoli with characteristic circular lamellations, similar to Samoma bodies. It's an autosomal recessive disorder, and it's mutations in SLC34A2 gene, leading to a dysfunctional sodium phosphate transport. It usually causes disease in middle-aged adults, respiratory failure, but usually indolent with slow progression. It has a sandstorm appearance on radiology, and your differentials include corpora amylacia, which is normal, dystrophic calcifications, and ossification. Let's talk about nodules. Aspiration, that's due to aspiration of food particles. It can be single or multiple. Risk factors include stroke, GERD, obesity, epilepsy, alcohol, where your swallowing reflex is compromised. You'll have airway center inflammation with giant cells and organizing pneumonia. Classically, you'll see degenerating food particles, as you can see here, but it may be focal, may be polarizable, especially some pill particles. You can also see Lymphoid pneumonia, and you can see abscess formation if it is super infected. Sarcoidosis. This is systemic idiopathic granulomatous disease with frequent pulmonary involvement. The diagnosis requires clinical correlation. It starts centrally in the lung with the large airways and hilar lymphadenopathy, and then extends outward with progressive fibrosis. The classic finding is this tightly formed, mostly non-necrotizing granulomas with giant cells. Eventually, they become more confluent and mass-like with increased hyalinized fibrosis. It follows lymphangitic distribution like bronchovascular bundle, interlobar septae, pleura. It's not in air spaces, and you'll have sparse lymphoid inflammation at periphery. There's no organizing pneumonia nor interstitial inflammation, and extensive necrosis, if you do see it, favors an infectious etiology. Note that giant cells can produce some endogenous polarizable material like calcium oxalate, and don't mistake as foreign material. Silicosis. This is caused by inhalation of silica and related minerals. Risk factors include those who work in construction, manufacturing, mining. The pathophysiology is the person inhales silica. That's engulfed by macrophages, and that forms aggregates that increasingly fibrose, hyalinize, and coalesce into nodules. Silica is birefringent if polarized. Coal workers' pneumoconiosis, aka black lung disease, is caused by exposure to coal dust, and it's common to see concurrent silicosis, quote, mixed dust, because there's similar exposure while mining. Histologically, you'll see dust-laden macrophages in and around terminal bronchovascular bundles, and there will be mild haphazard fibrosis and emphysema that can progress to large nodules with fibrosis, as you can see here. Vasculitis. The diagnosis often involves clinical and serologic correlation, often ANCA positive, granulomatosis with polyangiitis, formerly known as Wegener's. It is a necrotizing granulomatous inflammation, and it commonly impacts the lung, nasal cavity, and kidney. In the lung and head, you'll see histologically granulomas with geographic central necrosis, as you can see here, and associated vasculitis, as you can see here, and this forms ulcers and cavitating nodules. In the kidney, you can see crescentic glomerulonephritis, and it is PR3 ANCA positive, quote, C ANCA positive. Another vasculitis is eosinophilic granulomatosis with polyangiitis, formerly known as Church-Strauss disease. It's an eosinophil-rich and necrotizing granulomatous inflammation. It often impacts the lung, and it's associated with asthma and eosinophilia. Your MPO ANCA or P ANCA is usually positive. Rheumatoid nodule. Histologically, you'll see granulomatous nodules with central fibrinoid necrosis. You'll see a palisading histiocytes with lymphoplasmacytic inflammation, as you can see here. And this is the most specific pulmonary findings for rheumatoid arthritis. You can see diverse other findings, however, including pleuritis, follicular bronchiolitis, NSIP, UIP, etc. And you can see both in lung and pleura. Your differential diagnosis is granulomatosis with polyangiitis, infection, and so you want to get bug stains to rule that out. Fungal infections, often diagnosed based on imaging and lab studies. It may be focal or diffuse, particularly if the patient is immunocompromised. It often causes a granulomatous response, plus or minus necrosis, and so have a low threshold to get a GMS-PAS. Regardless of immune status, coccidioidomycosis, generally in the southwestern U.S. in dry soil, and you'll see spherules, plus or minus endospores, and known as valley fever. Histoplasma capsulatum, often seen in the Mississippi-Ohio River Valley, in soil/caves associated with bat droppings. You'll histologically see narrow-based buds, small, oval size, common to have subclinical infection with burnt-out hyalinized granulomas. If disseminated, you can see them in macrophages, as you can see here. Blastomycosis, often seen in the Mississippi, Ohio River Valley, and northeast in soil. You'll see the broad-based buds, round, uniform, thick, double wall. Paracoccidioides, seen in South and Central America, have a radial pattern. Often immunocompromised, you'll see Pneumocystis eurovetzii. It's ubiquitous and it infects immunocompromised hosts, classically AIDS patients. You'll see crushed ping pong balls with central dot and foamy alveolar exudate. Cryptococcus, ubiquitous in soil and bird droppings. You'll see a round, thick halo, variable size and can be pleomorphic, and you'll see narrow budding. Aspergillus, it's ubiquitous in soil. You'll see septae hyphae with 45-degree branching, can colonize pre-existing cavity leading to an aspergilloma or a fungus ball, and it can also cause an allergic response or be tissue/vascular invasive. Candida is ubiquitous in skin. It can be an oral contaminant in bronchoalveolar lavage or BAL, and you'll see budding yeast and pseudohyphae. Mucormycosis. This is ubiquitous. You see this broad ribbon-like hyphae with irregular branching and inconspicuous septae. Bacterial infections, often diagnosed clinically based on radiology and lab findings, especially usual bacterial pneumonia. You can get Mycobacterium tuberculosis. Worldwide, many people are asymptomatically infected, leaving behind calcified nodules/lymph nodes known as Ghone complex. This can reactivate, leading to active cavitating infection, often in the upper lobes. It can disseminate more widely if the patient is immunocompromised. Histologically, mostly see necrotizing granulomas and fibrosis, and thus have a low threshold for getting your AFB stain. Nocardiosis. Nocardia is a gram-positive filamentous bacteria. It infects the immunocompromised and highlighted by both AFB and GMS, and it looks like slender, tangled strings. Actinomycosis. Actinomyces is a gram-positive filamentous bacteria. It's a commensal in our oral cavity, and it can cause abscesses with distinctive sulfur granules. Pulmonary hyalinizing granuloma. This is the pulmonary counterpart to fibrosing mediastinitis. It's often considered an exaggerated response to a remote infection, most often histoplasmosis. It can also be associated with IgG4 related disease. You'll have single or multiple slow-growing nodules, and you'll have well-circumscribed acellular hyalinized collagen, as you can see here. You can see scattered foci of chronic inflammation. Metaplastic ossification. This is mature lamellar bone, and it's often incidental finding. It's frequently in response to injury, such as scar, aspiration, granulomas, apical caps, etc. And here you can see mature lamellar bone and some actually hematopoiesis as well. Apical cap. This is a subpleural fibroelastotic scars seen most commonly in the apices of the upper lobes. It's unclear etiology, but you'll see predominantly elastotic fibers with intermixed collagen. It's a triangular shape with broad pleural base and can radiographically mimic malignancy. If diffuse, pleuroparenchymal fibroelastosis. This is a rare type of interstitial lung disease discussed separately. Pulmonary Langerhans cell histiocytosis, aka eosinophilic granuloma. It's considered a reactive proliferation as opposed to extrapulmonary Langerhans cell histiocytosis, which is neoplastic. It's strongly associated with smoking, so you often see other smoking-related changes. Architecturally, you'll see stellate nodules centered around airways with surrounding cystic areas. Early changes include numerous Langerhans cells, which cytologically have grayish cytoplasm with groove coffee bean nuclei, as you can see here. It stains with S100, Langerin, and CD1A, and it has associated eosinophils, as you can see on the right side of the photo, and late changes include increased fibrosis. Other non-neoplastic mass-forming lesions include berylliosis, amyloidosis, light chain deposition disease, parasitic infections, vaping, which can cause nodular injury, Ehlers-Danlos syndrome from spontaneous vascular injury. Round atelectasis. This is the infolding of lung into underlying parenchyma caused by pleural fibrosis or retraction and can simulate a mass. It's most common in the lingula and requires radiographic correlation. Histologically, you'll have normal appearing lung tissue with overlying pleural fibrosis with no obvious mass-forming lesion. Near normal, you can have emphysema, which is airspace enlargement due to alveolar septal destruction without significant fibrosis. It's a common background or incidental finding in lung and is often classified by location. Central lobular is destruction near small airways, classically associated with smoking and upper lobe predominant. Emphysema and chronic bronchitis is chronic obstructive pulmonary disease, COPD. You can also see with co-workers pneumoconiosis and eventually expands to panlobular/acinar. Pan-acinar, this involves entire lobule from beginning. It's classically associated with alpha-1 antitrypsin deficiency and is lower lobe predominant. There's also risk of liver disease with alpha-1 antitrypsin deficiency. Pulmonary hypertension. This is a clinical diagnosis. You'll have increased pulmonary vascular pressure, and common causes include heart failure, lung disease like UIP. It can be primary, idiopathic. Pathologic findings may not correlate with symptoms. You'll see histologically medial hypertrophy of the arteries and veins, intimal proliferation and fibrosis. And architecturally, you can see plexiform lesions, fibrous webs/plugs, like colander-like, and emboli and thrombi. Note that recanalized thrombi from a pulmonary embolism are also plexiform. If the lesion is in a large elastic artery, think pulmonary embolism. Birt-Hogg-Dubé syndrome. This is autosomal dominant and arises from mutations in the folliculin gene. And you'll have multi-organ manifestations. In the lung, you'll see variably sized thin-walled cysts underneath the pleura near septae or lower lobes, and it can rupture, leading to pneumothorax. In the skin, you'll see fibrofolliculomas. Kidney, you'll see hybrid oncocytic neoplasms, your chromophobe renal cell carcinoma intermixed with oncocytoma. Constrictive obliterative bronchiolitis, mainly say obliterative bronchiolitis in transplant setting. Here you'll see fibroinflammatory scarring of bronchioles. You'll see scarring between the epithelium and smooth muscle, and it can eventually obliterate the lumen. The elastin stain can highlight elastic layer of obliterated airway and confirm it was there, usually with a remaining paired artery. Possible causes include infection, fumes, toxins, medications, connective tissue disease, especially rheumatoid arthritis, etc. Amyloidosis, it can be localized, just the lung, versus systemic. Localized amyloidosis can be nodular or diffuse. Regardless, it appears similar to elsewhere. You'll see this waxy pink protein deposition, and if you do a Congo red stain and polarize, you'll see apple green birefringence, as you can see here. Foreign material emboli. With intravenous drug use, there can be microcrystalline cellulose emboli, as you can see here. It's refractile under polarized light, and it can cause pulmonary hypertension. Bone marrow fat emboli can be seen after bone fractures, including after CPR. It's a finding that you can see in autopsy cases for those who received CPR. Amniotic fluid emboli can occur during pregnancy/birth. You see fetal squamous cells and other fetal tissues in the pulmonary vasculature. It can cause sudden death, hypoxia, and DIC. And here you see amniotic fluid emboli here. Lung transplantation. Surveillance biopsies are often performed to look for signs of rejection at regular intervals post-transplant, 6, 9, 12 months. Acute cellular rejection. For adequate sensitivity, you need 5 pieces of expanded alveolated and multiple levels. Acute cellular rejection is based on the presence of perivascular and interstitial T-cell rich infiltrates. You can also see lymphocytic bronchiolitis with a band-like T-cell rich chronic inflammatory infiltrate in the submucosa of bronchioles, which have no cartilage in the walls, as opposed to BALT, which is bronchus-associated lymphoid tissue, which is well circumscribed and B-cell rich. Note, perivascular/interstitial and bronchial chronic inflammation is not specific for rejection. Infection like CMV, PCP, and post-transplant lymphoproliferative disorder can look similar, so consider other options, particularly if there are lots of neutrophils or plasma cells, features that favor infection. Chronic rejection. Obliterative bronchiolitis. This is a progressive airway lumen obliteration by inflammation and fibrosis. It's hard to see on surveillance biopsies, often a clinical diagnosis with reduced FEV1. Elastic stains can be used to highlight obliterated bronchioles. It's synonymous with constrictive bronchiolitis in non-transplant setting. Chronic vascular rejection. This is myointimal thickening and fibrosis within arteries and veins, not often seen in biopsies. Antibody-mediated rejection. This is less well defined than in other organs. Requires 1. Clinical dysfunction, 2. Positive circulating donor-specific antibodies, and 3. C4d immunoreactivity. On H&E, you'll see neutrophilic capillaritis and neutrophilic septal margination. IHC immunofixation, you'll see C4d is strong, linear donut pattern of staining in septal capillaries. This is a transplant acute rejection grading chart that Dr. Schaberg has provided, and I will leave for your reference. Here's a transplant chronic grading. And here are very helpful tables of the histologic findings of idiopathic interstitial pneumonias that I will leave for your review. And chart with diseases with bronchocentric granulomas. Thank you so much for watching. Thank you to Dr. Schaberg for his excellent notes as always. We'll see you next time. Bye.